Assalamu alaikum. Good afternoon, everyone, or good evening. Uh, this is Dr. Abdul Majid Zubaydi. I'm a cardiologist and the president of the Emirate Cardiac Society. I'd like to welcome you tonight to another symposium on the ECG and ischemic heart disease. We've been conducting this series of symposia over the last 2 years, and we had a positive feedback. That's why we are keeping it and we're repeating it regularly. Tonight, I have colleagues of mine, Dr. Sharif Bakir and Dr. Amrish Agarwal. Both are well-known cardiologists in Abu Dhabi and Fujairah, and they will share with me the interaction in this hour and a half of this symposia. So without a lot of delay, I'll share with you again the objectives of why we're doing this. Sometimes people think that ECG is very simple and why are we spending a lot of time? But I can tell you, understanding ECG is key in saving lives. Ischemic heart disease is the most common cause of death in UAE and worldwide. And if you can identify the patient, especially the patient who has a heart attack, very early, then you will triage him early, he will get treated early, and you will save lives. And this is well proven. Interpretation and understanding the limitation of ECG is very key also. Some people think that electrocardiogram is, a very sensitive, specific test. No, you have to understand the limitation of that. So just this quick diagram or graph shows you 4 bars, okay, 4 columns. The first one, if you miss an MI, then the chance of death of that patient is about 50%. If you send him home, you miss that diagnosis. And if you admit the patient only and you recognize and admit only and you don't give him a lot of treatment, then the chance of death is about 15%. Of course, if the patient goes for primary PCI, the chance of death is less than 5%. So recognizing this patient, triaging them early is very important. I'll show you a few cases to understand the importance of doing an ECG and reading it. 38-year-old presented to an urgent care with chest pain. This is a recent case that I got to see. And this patient I was involved in, so 38, he presented to an urgent care. The urgent care physician looked at the case. He thought maybe this pain is dyspepsia, get PPI, and ask the patient to return back if there's a chest pain. This is the ECG. ECG is not so dramatic. There's some T waves changes. Retrospective, you would say this is a hyperacute, and maybe they represent an acute ischemic event. So the patient went and he had a referral in his hand, and he was supposed to go to another hospital for more consultation. Unfortunately, the patient died on his way to the referring site. So this patient should have been recognized early, have been triaged, got an ambulance or observation at least for a longer period of time. So sometimes if you think an ECG is normal or doesn't show an acute ischemic event, that does not rule out acute coronary syndrome. This case, second case, 61 with epigastric pain, similar scenario as the previous one. Okay, and basic blood work is unremarkable. This is his ECG. Look at it, nothing dramatic. Look, unfortunately, the recording is from another hospital. But I like to share it. Lead 1, 2, 3, AVR, AVL, AVF on the first line, and then the second line shows you all the chest leads. Nothing acute. This patient, same thing. He was given treatment, diagnosis of dyspepsia, and asked to return back. He returned back just a few hours later with this massive inferior ST elevation, inferior lateral, whatever you want to call it. And it's massive inferior lateral MI. Again, another case, and we can repeat these cases. All these cases, I can tell you, happened over the last just few months. 42, young, smoker, presented with upper abdominal pain, sent home with the diagnosis of dyspepsia. Now he comes again with a cardiogenic shock, massive anterolateral MI. He arrested and they could not resuscitate him and he died. Fourth case, the same thing, 62, hypertensive, diabetic. This is his ECG, you know. He didn't have an ECG. He's had a shoulder pain only and no ECG was done. He presented a week later and this is, you know, diffuse ST and T wave changes and he had an infarction. So make sure when you have someone with chest pain, your threshold of ordering an ECG should be, you know, very low. Just do it, you know, do an ECG, especially in the right patient. Jaw pain, patient can present with jaw pain only, can present with epigastric pain, you know, shoulder pain, chest pain, arm pain. So, you know, if you have someone who you suspect, you need to do an ECG. And if you order an ECG, you need to interpret that ECG. You don't just ignore it and put it on the side. So you need to identify the diagnosis. It will help you in risk stratifying the patient. And of course, you know, to be competent in ECG, you need to practice the reading. You need to, you know, to visit those websites that shares those ECGs, books, symposia like this one, and so on. And last, I would just to tell you that how important this is this is a study that was done on competency, on residents, fellows, and consultants. And I can tell you, if you give fellows and residents and GPs ECGs, the competency is not great, especially in diagnosis, some arrhythmias or some subtle ECG ST elevations. They may miss it. And in these, you know, the sensitivity can be up to 50%. Some, you know, the specificity is down, less than 40, 60%. So competency, and this is published in Journal of American Heart Association, the competency, if you don't practice, you will not be competent reading ECG and you will be subject to missing cases and losing lives. So it's very important that we practice. It's very important that we attend such cases. Similar study again. So this is a quick introduction just to tell you that, you know, reading ECG is very, very important. A lot of our physicians are not up to the level of competency in reading it. And of course, ECG enough sometimes is not enough to diagnose coronary heart disease. So I will stop here. And this program, again, is going to be myself, Dr. Sharif Bakir, Dr. Amrish Agarwal. So the next step would be a system, an approach to read an ECG. Dr. Sharif Bakir previously shared with you his approach. You can develop your own approach, but make sure your approach or your system of reading the ECG does not miss anything. So, and then every time you read a 12-lead ECG, just go systematic and go and use your approach. Dr. Sharif is going to share with us, you know, the way he reads ECG, and we will use it throughout our symposia. After Sharif finishes his brief, you know, talk, we will have a challenging cases, and then we will move to a drill where we'll do a lot of, we'll try to do many cases on as a flash reading. Yeah. So we'll go ahead to Dr. Sharif, and Dr. Sharif share with us your slides.
Stop sharing so I can share my screen. Can I share my screen, Dr. Zubedi?
Go ahead, yeah.
Can I share my screen? Yeah. Now I will share my screen. Did you see my screen, desktop? Did you see it? Share. Let me to launch. What happened? Wait a minute. Let me to see. Oh, what happened now?
Don't launch it again, Dr. Sharif. Just share the screen.
Well, I'm sharing the screen, but it's...
No, the screen is shared. Just select the window.
Huh?
The window of the ECG. The screen is shared already. Just share the ECG window.
You are seeing me now, yes? Now you can see my slide. You see my slide now?
Yes.
Okay. So, good evening, everybody. I mean, as Dr. Zubedi said, that ischemic heart disease is a dangerous situation, need quick action. We have to understand that. So what does it mean? That means that when you are having patient with chest pain, you have to respect whatever the chest pain looks typical or atypical. Especially also, of course, you have to put the age and the risk of the patient. So first of all, we have to respect any chest pain, and then try to see what to do next. So, for example, the ECG, we have to know how to interpret the ECG. You have to put scheme in your mind, as Dr. Zubaidi tell us. But first, we have to understand, when you ask for any test, like the simple one, which is the ECG, you have to do first, it have to help you in diagnosis. Second, in prognosis. Also, it have to be follow-up, which means that if I do the first ECG and it's normal, does not mean the story finished. I have to go to the next, because if I still believe that this chest pain is cardiac, I have to do follow-up. So this is the importance of the ECG. Simple, you can do it quickly, and you can do follow-up. The second thing, it is high sensitive and high specific, but normal ECG does not exclude heart attack. This is very important. As Dr. Zubaidi was telling you, that you have to put a scheme in your mind, which is rate, risk, axis, interval, segment, others. Because if you are looking for certain things in the ECG, you will miss some other things. And this is we'll see when we do the test with Dr. Zubaidi. First of all, we have to understand ST elevation. What is the ST elevation when you are looking for the ECG? What is the ST elevation? ST elevation, I will give you a quick look, and then we'll go after that when the ECG. ST elevation is something which means that the ST is elevated at the J point. For example, what is the ST segment? ST segment represent, as we said, the phase in the cardiac cycle between the ventricular depolarization and repolarization. You have to look to the isoelectric line, and then to the TP segment, and then to measure the J point. For example, here, let me to close this one. So here, as you see, this is the PR interval, and we are looking the ST to the TP segment, and then we have to look to the ST away from. If you decided that your ST segment will be from, you have to look to the J point, either to relate it to the STP or you relate it to the J point and after the QRS complex. So we said that ST segment elevation should be at least 2 millimeter elevation, or 1.5 millimeter in women, as we said, from V1 to V3, or 1 millimeter only elevation in the limb blades. This is very important. Ischemia. When you look to the ECG, for example, if you look to the AVR, now we know that ST elevation in AVR, this is indicating a left main coronary artery disease. So you have to understand it. So ST segment depression 1 millimeter in 8 or more surface lead, this is coupled with ST segment elevation in the AVR or V1, suggests left main. Or left main equivalent, which means that you look for the more than 3 vessel disease. So AVR, important to look for the ST segment elevation. Another, also you have to remember when you are recording ECG that sometimes you need to go to V7 and V9. This is just introduction. I will show you all of this, but I want you to remember. Sometimes you have not to go to V6, you have to go to V7 and V9, especially if you are thought that there is ST segment depression in V1 and to V3, and then you have to look for this could be posterior MI. So you have to understand it. So ST segment depression in V1 to V3, this is very important because this could be representing a posterior MI. So this is why you have to go back and to do V7, V9, V8, V9. Another important point also, when you detect ST elevation in the inferior lead, like lead 2, lead 3 AVF, you have to go back also and do right V3 right and V4 right. Why? To see if there is right ventricular infarction. So just a quick, this is the ST segment elevation from the baseline. And we have to know that this is the normal. This is the peak T wave, as Dr. Zubaidi has shown you, one of the ECG have peak T wave. Then you have the progression of the ST. If the patient come too late, this is, you will find the Q wave start to appear, T wave inversion start to be there, and then the ST segment will return back to the normal. This is recording minute to hour, days, and after that. So also the ECG can give you an idea about which vessels are occluded. This is very important. So to understand what I'm trying to say quickly, that sometimes you will, for example, hyperacute wave, this is a T wave, which is more than 5 millimeter, often happen early in the air function. Something because some of you like what is called the de-winter T wave, Wilson syndrome, pseudo-normalization. All this, I will just go quickly, that sometimes when you have hyperacute T wave with ST segment depression in the precordial lead, this is often indicating ST equivalent, which means that you are talking about LAD occlusion. Also, if you have biphasic T wave in V2 to V3, typically up-down biphasic T wave, this is wave occur in the pain-free patient with history of recurrent angina. Yani if you told this patient, I have angina yesterday, but now there is no ST segment vision, this indicate critical lesion in the LAD stenosis. Also, pseudonormalization. If someone have infarction before and they have T wave inversion, and now the T wave become upright, this is strongly suggestive of ischemia. This is now we are talking about acute MI and the ischemia for someone who having chest pain 1 or 2 days before. You have to also know the name, that the nomenclature. When we say R wave capital like this means that the R is tall. When we put it small like this, we are talking about R is small. When we are talking the QRS complex like here, this means that the Q are deep and the R is small. So this is, you have to be familiar with the nomenclature. By the way, I am talking to all of you. Some people have an idea about the ECG. We are not talking about how to interpret ECG from zero. You have to have an idea about the ECG to understand what we are talking. So let us to go quickly. We have what is called the 10 rules for the normal ECG. The 10 rules is very simple. Rule number 1, PR interval should be at least 120 to 200 milliseconds, or 3 to 4 small square, 3 to 5 small square. Rule number 2, P wave should be upright in lead 1, lead 2, and V2 to V6. If you find that the P wave is not upright, you have to ask yourself if this is dextrocardia, or the most common thing is the nurse or the one who's putting the T wave, the leads are put it wrongly. You will find T wave inversion in lead 2, for example. Number 3, rule number 3, the width of the QRS complex should not exceed 3 small square or 2.5 small square. If it exceeds 3 small square, you are talking about wide QRS complex. Rule number 4, we have to know that QRS complex should be dominantly upright in lead 1 and lead 2. If you find it not upright in lead 1 and lead, there is something. You have to ask yourself why. And the QRS complex should be RS in V1 and the QR in V6. RS in V1 and the QR pattern in V6. Rule number 5, the QRS complex and T wave tend to have the same direction, and the R is dominant. Rule number 6, all waves are negative in lead AVR. This is very important to understand. Then we have to go to rule number 7. What is rule number 7? That V1 to V2, V3, V4 is like this. The R wave in the precordial lead must go from V1 to V4. So why this? Because the horizontal plane is the 6 chest lead. We have to know like this V1, V2, V3, V4. So we are going on this way. So the rule number 7 from V1 to V6 is like this. The R wave in the precordial lead must go from V1 to at least V4. And the S wave in the precordial lead must go from V1 to V2. Number 8, ST segment should be start iso except V elevated. So not everybody have ST elevation in V1 and V2 is indicating myocardial infarction. So we have to be careful about that. This could be what's called early repolarization. And then rule number 9, this is rule number 9, there should be no Q wave or only small Q wave less than 1 small square in lead 1 and lead 2 and V2 to V6. 1 small square in depth and 1 small square in width. If you find Q wave more than that, you are talking about all the infarction. Rule number 10, the T wave must be upright in lead 1 to V2 to V6. So what is the characteristic change in the in acute myocardial infarction? The ST segment elevation over the area of the damage. ST segment depression lead opposite to the infarction, what is called the reciprocal, and pathological Q wave, and reduced R wave, and inverted T wave. So, for example, ST elevation, this is occurring in the early stage, occurring the leads facing the infarction. Slight ST segment elevation may be normal in V1 and V2, as we said. And then we have the deep Q wave. This start to occur and form once the infarction start to be more in time. At least we'll find the Q wave. It will be more in depth, more than one small square in depth and one more small square in width. Then the T wave change, the late change will come. This you are talking about now hours, and mean that the infarction have been occur and becoming more in time. As Dr. Zubeidi said, you have to detect early myocardial infarction. Pain with ST segment change, this is very important. This is the anterior MI, while sometimes the left bundle branch block can mimic. So according to the rules, if somebody came with chest pain and you have left bundle branch block, no ECG to compare, consider it as acute myocardial infarction until proved otherwise. Then we'll have what is called the left bundle branch block and MI. This will find that there is QRS, it is lost the discordance, because usually the QRS complex is the ST, they are discordance in V5, V6, or you find loose discordance in lead 3 and AVF. So this is called what is called, some people like this type of criteria, which we said that if you find ST segment elevation more than 1 millimeter, this is a 5 score. This is called the score. We don't want to go into this. Right bundle does not mimic the myocardial infarction. You have to understand this. And the axis, there is very simple way to detect the axis. You have to look to lead 1 and the AVF. If they are both in the same direction, this is the normal axis. While if you have lead 1 in there is deep, S, while AVF R, which means they are checking hand each other. This is called the right axis. If you find lead 1 upright and AVF away, which means the F down, which means both of them are against each other, this is called the left axis. But we have to know there is something called left axis and something called pathological left axis. You have to look to lead 2. If you find lead 2, the S is more than the R, this is pathological axis. The anterior infarction usually get in V1 to V2, V3, and up till V4. Inferior, you look to lead 2, lead 3 AVF, and in lateral, you look to lead 1 AV and AVR, lead 1 and AVL, or from V5 to V6. This is to give you idea about where to look. I am going fast and quickly because we have to give space for the test that Dr. Zubeidi will show to us. Just before leaving my talk, I will return back to you to this. You have to understand this is very important. Introduction. First, you have to look to the rate. You have to look to the risk. You have to look to the axis. You have to look to the interval, which means the PR interval, QT interval, and the segment, which means ST segment elevation or ST segment depression, other which mean left bundle or right bundle. You have to create a scheme in your mind when you are reading the ECG. This is the idea of looking to the ECG. Don't look just only for the ST segment elevation or depression, because you will miss many things from this. I hope, Dr. Zubeidi, I have go very fast, quickly. I don't want to go deep, because to allow for you for the cases. I will stop sharing now. I stopped sharing. Are you with me, Dr. Zubeidi?
Thank you. Thanks, Dr. Bakir. Thank you.
I was very fast just to allow for the cases.
Yep. Thanks. So, yes, I know I can hear you. So what I'm going to do is we'll move as we are used to this. We will, sorry, I have to stop sharing this one. I'm intended to share another one. So what we'll do is we will, we have a presentation, which is a group of cases. Sorry, guys. Uh, uh-huh. Uh, I'm just trying to open the presentation that I have here. Okay. And then we'll. So Amrish, okay, there you go. So this is this is your, I guess, your first time with us here, but it's an interactive reading of a 12 lead ECG where our audience would, would hear this interaction and our interpretation. So it's like interpreting the ECG by the expert. And we'll try to use the scheme or the method Dr. Bakir used. So what I'll do is I present the cases, and then we'll go from there. So can you see the slides?
Slides.
Yes.
Yeah, we can see the slides. Thank you very much.
You can see it. Okay, good. And Dr. Bakir. So, for our audience, Dr. Amrish is a senior consultant in Fujairah Hospital, and he is a professor in the university. Dr. Sharif Bakir is a senior consultant cardiologist also, and he worked at SKMC and SSMC and Ministry of Health, and now he is in the private sector. So they will, the three of us will go over these cases, and we will, we'll interpret them. So first case, 64 male with diabetes and smoker. He had chest pain, sweating, presented to an MPCI hospital, 30 minutes to reach a PCI capable hospital. So such patients usually we refer them for PCI, and that's his ECG. So so the ECG, if we want to go systematic and read this ECG, Dr. Sharif, so we'll go with the rate, rhythm, axis, interval, and segments as you shared with us. I don't know if Dr. Sharif is there. If not, Dr. Amrish. So we just go systematic, and I think,
Do you want me to read this?
Yeah, just a high level. We can go together and
Very
just
well. So
this,
the rhythm is sinus. For every P wave, there's a QRS complex. Every
Excellent.
QRS complex, there's a P wave. The rate is not tachycardia, not bradycardia. The rate
Exactly.
is a good rate. So maybe
About 100 maybe or
100
so.
or 100 beats per minute, yes. And
Exactly.
there is obviously a grouping of ST elevation. So we can see clearly that there is a
Right.
ST elevation in lead 2, 3, and AVF.
Yes.
And from the previous presentation, we saw there's these three leads actually point towards the inferior wall of the heart. So this patient is having inferior myocardial infarction. And then there is a Q wave already established in lead 2, 3 AVF. So this
Right.
infarction is probably, we can say that temporarily is not in the first hour or second hour, but it is a little bit away from the time. And there is some reciprocal changes in and of ST7 depression in lead B1 and B2.
Exactly. So thanks, Amrish. I mean, this is a sinus, and it's very important that you look at the rate, you look at the rhythm, as stated early. Sometimes we jump into the diagnosis, but it's very important to understand the rhythm, because MI has complications of arrhythmias, either brady or tachyarrhythmia. So you want to make sure that your patient does not have that arrhythmia. And of course, you pointed out to the inferior ST elevation that is already having established Q waves. Also, there's a dominant R waves over here, indicating maybe there's a posterior component with the ST depression, as you mentioned clearly, those reciprocal changes. So inferior, posterior, but still in sinus rhythm without any major
Dr.
complications.
Abdul-Majid, from the audience, somebody asked, what about the axis in this ECG?
Yes, exactly. So axis is very important. So axis, the way we look at it, we look at lead 1, and then we look at AVF or lead 3. So we look at here, it's a positive in lead 1. So that is pointing towards the, towards the normal axis. And then here it's almost equivocal. So still, I would call this normal axis, Amrish. What do you think?
Yes, because in the axis calculation, we don't take into account the Q waves. So if you omit the Q waves from the AVF is still like 4 millimeters positive. So the axis is a normal axis. So you can get a loss. So the MI computer makes the axis calculation a little bit challenging because you have a loss of mountains. So the R will get lost. So if you have an R wave which is lost because of myocardial infarction, it doesn't change the overall axis. The overall axis remains like what the patient had before the myocardial infarction.
Exactly. So, positive and probably a positive here. So that makes the axis normal. So the next slide is a summary. So we want the message to be clear. So what is ECG criteria? And this is a definition by the guidelines and by the different societies of ST elevation myocardial infarction, where the patient deserves to go for a thrombolytic or a reperfusion strategy, primary PCI or thrombolytic treatment. So if we look at this case, at those definitions, we have the ST elevation of more than 2 millimeter in V2, V3, or 1 millimeter in 2 other contagious leads. In this patient, we had more than 1 millimeter in lead 2, 3, and AVF. So that meets the criteria. So it's very important to understand what is the definition of ST elevation myocardial infarction on an ECG. So either you have an ST elevation or you have a new left bundle branch block on the 12 lead. And the new left bundle branch block, if you have an old ECG to compare, that's good. If not, then a left bundle branch block, an ECG is considered new till proven otherwise. Amrish or Sharif, any comments on the definition, the universal definition of STEMI?
So you can please answer it.
Yeah. So basically, yeah, exactly. So that's the definition. One of the things I noticed is some people, and we had these cases occasionally, is some people diagnose wait for troponin in STEMI. So troponin does not have any role in STEMI diagnosis. It helps in the prognosis. Of course, you will order it, you will get it late, but don't wait for troponin if you suspect STEMI. You have to take care of the patient and move him to where a reperfusion therapy. I hope this is clear. Now, case 2, 44-year-old male with hypertension and diabetes. He presents with chest pain, sweating, and dyspnea. Okay, this is his ECG. So, Dr. Bakir, are you there?
أنا شايفك، أنا مش شايف السكرين.
شايف السكرين؟
لا، شايفك أنت، مش شايف السكرين. استنى.
Okay, maybe you need Amrish. You can see the screen, right? You can see the ECG.
Yeah, I saw it. Yeah.
Yeah.
So now, if we return back to what Dr. Zubeidi was saying, and as we said, rate, rhythm, axis, interval, and others. So I want to go from this ECG. What is the rate, Dr. Zubeidi? What is the rate? How to calculate the rate for them?
So the rate is, looking at the large boxes here, it's about 1, 2, 3. I would say about 75, 80.
Okay.
And it's minus rhythm.
Within normal. Okay.
Yeah, normal. Exactly.
The rhythm is normal or abnormal. How to know the rhythm? Each P wave should be followed by QRS complex in a regular manner. So from this one, it looks sinus. Some of the ask about the PR interval. PR interval looks here normal because PR interval is to be from 3 to 5 small square. So the PR interval are normal. So rate, rhythm, axis. How to look to the axis? We said lead 1 and AVF. So
And
the
AVF,
yeah, it looks normal. You have any comment?
Yeah.
So the axis normal. Rate, rhythm, axis, interval. Any Y, any PR interval prolongation on any QS, QT prolongation? No, looks normal.
Looks
Yeah.
normal.
Interval.
Comment, Amrish?
Actually, from the audience, a lot of people have answered all these things. So we have to really appreciate. A lot of people have picked up, but obviously, you, as chairperson and Dr. Sharif, Abdul Majid and Dr. Sharif, they are going slowly so that some people, there are 200 people in the audience. If some people are not following, so they can be, the concept can become clear. But from the chat box, a lot of people have answered everything perfectly.
Yeah, so Amrish, what we are trying, most of the people, if to look to this, he will say, yes, ST segment elevation. It is attractive in lead 1. And
yes.
Can you return back?
Yes.
Lead 1 and AVL, and also in from V1 or V2 to V3. But what our aim is not let them to attract what is obvious, because we don't want them to miss anything. You get the point? The idea from the ECG is not to miss, because yes, it is obvious. If you look to ST segment in lead 1 and AVL, they are elevated. Everybody agree? And also in V2 to V3, it looks elevated. Yes, Zubaidi? Yes,
Yeah.
Yes.
Yeah.
So idea is systematic approach.
So yeah, so this is what, yes, there is. So lead 1 and the AV and the AVL looks for which from Nazir, somebody said yes, agree. Yeah. So lead 1 and the AVL, it is the high lateral. Okay, V1 to V2. If you look to V1, it is suspicious, yes, but not elevated. But because of the V2 and V3, of course, we have to respect the V1. So there is ST segment elevation in the high lateral and in the anteroseptal. What do you think, Amrish?
Yes.
So clearly, I mean,
my mind is going, why such an odd combination that this man has got an ST elevation and lead, ST depression in lead 2, 3 AVF, ST elevation, lateral ST elevation, and septal ST elevation. And, and there is no ST elevation in V4 and V5.
Yeah. Also, what Dr. Amrish mentioned is look to the inferior lead, lead 3 and the AVF, ST segment depression. What we call this? We call this reciprocal exchange. What is the importance of reciprocal exchange? This is to tell me that this is acute MI, because sometimes you will have ST segment elevation in some lead because of pericarditis. For example, it will be taking different lead, cannot be judged to, cannot be, point to one certain location of the arteries, and there will be no reciprocal exchange. This is very important.
Okay. Thanks, Dr. Vakir. So, in summary, sinus acceptable within normal rate, and the axis is normal. We looked at the axis, and then we have the intervals are okay. We look at the PR and the Q and the QT and the QRS, and the segments. There is ST elevation involving the lateral leads and some of the anterior leads, indicating anterior ST elevation myocardial infarction associated with reciprocal changes in the inferior leads. So clearly there is an anterior STEMI. And the second message, so the first I shared with you the universal definition of STEMI, which is very important to be aware of. The second is you have to be familiar with the localization. Here we debated, Amrish was asking why lateral plus septal and this combination. So it's very important that you can localize your STEMI. And the reason behind that is it helps you in the prognosis. Anterior STEMIs are worse prognosis than inferior. You know, if you're having an anterior and inferior, if you're having a diffuse ST elevation, you may suspect a pericarditis or other causes other than myocardial infarction. So the localization indicates which artery is involved, and then these arteries helps in the prognosis. So, you know, proximal, like the case that we saw, anteroseptal or anterolateral, indicates a large myocardial infarction. So, we have inferior MIs, anterior, anteroseptal, anteroapical, anterolateral, lateral, and posterior. And I will show you a posterior infarction, which on the 12 lead is
Can I ask a question?
elevation.
Can I ask a question? someone like this, do you need to wait for the troponin?
Yes, so we pointed out to this early, Dr. Bakir, is still there's this misunderstanding in STEMI, no need for troponin.
Yeah.
Troponin in STEMI is for prognosis only. You look at it, if the troponin is very, very elevated, then you look
This
at
is the
it.
theory of
Yes,
plus in 10 minutes, give you the diagnosis immediately.
okay. Now, and the third case is 69-year-old. So we talked about the definition. Now we talked about the localization of MI.
Yeah.
Now the third case, 69 male diabetic smoker, presents with chest pain, sweating, and he comes as a walk-in to the emergency. This is his ECG. So what do we see here? So now we're getting into the complication of MI. So ECG can help you identify not MI only, not ST elevation MI, but also the complication. Is it a brady or is it tachy, and so on? Is there what kind of arrhythmias is there?
Some of the audience write brady, but this is not what we want. We want to go systematic. Brady, yeah. So rate, rhythm, axis, interval. This is very important. Because brady, okay, but what kind of brady? You will not look for, you'll not diagnose it. Yes, he writes something. Yeah, so this is very important. Can you go rate, rhythm, axis, interval? Amrish, can you comment, Amrish?
Oh.
Yes. Well, certainly the audience are coming to the conclusions, and gradually one gentleman, doctor, he put the correct diagnosis of this one. So certainly when you go to the rate, rhythm, and the axis, obviously this man is having a bradycardia. And when you say the bradycardia, what type of bradycardia it is that? It appears certainly that the QRS complex is coming regularly. So if you see grossly, and if you don't measure it, you can measure by caliper, but you will see that the QRS complex coming regularly. But we obviously cannot see the P wave. So there is no clear obvious P wave seen in this ECG. There are some notches which we can look at the P wave. Yes, it is possible. Some may be P wave. It is possible the P waves are marching to the QRS complex, but certainly we cannot see a distinct P wave, and the QRS complex is coming at the bradycardia side. So 300, 150, 175, 60, 48. So maybe it's around 30 beats per minute, or even 30 or 30 less than 30 beats per minute. So a significant bradycardia with the ST elevation in lead 2-3 AVF. So the same, the pattern of MI which you have seen in the previous patient is now also, there is a good amount of ST elevation in lead 2-3 AVF, which indicates that this man is having an inferior MI. And Dr. Sharif pointed out that MI, if accompanied along with the reciprocal changes, makes the diagnosis of MI more certain. So in this patient, there is a ST depression in lead V1 to V3. And once again, what we have seen from the previous talk, that there should be a progression of R wave. This patient doesn't have a progression R wave. There is actually a tall R wave in V1, V2, V3, indicating that there's a posterior wall myocardial infarction also.
And also another important point, we have to know that inferior wall infarction, we have the blood supply from the right coronary, which supply the SC node and the AV node. And this is why you will find people with inferior MI, they can develop complete heart block, they can develop bradycardia, because the SC node and the AV node both are supplied by the right coronary. And this is to tell us that this most probably is very proximal right coronary, or also we have to look for the circumflex. What do you think, Dr. Zubaidi?
Yes, so this patient, as you guys stated clearly, I mean, this patient is having a complete AV block. The sinus, I cannot appreciate the P waves except for some blips here, but most of it is almost a flat line. So there is a ventricular response, maybe a high up in the his bundle, but clearly there's a complete AV block secondary to inferior ST elevation and a posterior. So inferior, because there's ST elevation involving the inferior leads, and then there is a dominant R wave with ST depression in V1, V2, V3, indicating a posterior infarction. So it's inferior, posterior. This is complicated with this AV block with a severe bradycardia. Of course, this patient needs to be treated rapidly for reperfusion. So most likely someone already, we have a good interaction on our chat box here. A lot of people are sharing their thoughts and ideas. And I think as they stated, someone said dead man sign. Yes, so this patient, you need to triage them very first. You need to open their artery, you need to put a pacemaker, and of course, I mean, they can survive this bad, you know, infarction. So very important point is to be familiar with the complication of STEMI, especially the ECG findings, how the ECG can guide you into those complications. So this patient had inferior STEMI, but also he had a bradyarrhythmia. So 40% of inferior wall infarction involves the right ventricle. The addition of right-sided ECG leads, especially V4R, will help in that diagnosis. We don't have it in the previous ECG, but RV infarction is very key. And RV infarction can differentiate between if the circ or the RCA, if a dominant circumflex RCA is the culprit. The second thing is the RCA subperfuses the sinoatrial node, the heart blocks and bradies may occur. High degree heart block, as we saw in the previous ECG, can be seen in 19% of patients with acute inferior wall MI. In our patient, he had a very bad bradycardia, severe bradycardia, but of course, I mean, you can have a heart rate of 50, 60, and sometimes you may not notice it. So that's why it's important to go systematic. So be familiar with the complication, arrhythmia complication associated with the STEMI. Either it's a brady or a tachyarrhythmia. Any added points, guys? No. So next case.
Dr. Dwivedi, would you like
yes.
to highlight to the audience at this particular point, in the absence of blocks or the RV infarction, if there is a way we can distinguish from the ECG, the infarction pattern of right coronary artery versus the circumflex, if there is a distinctive pattern between the lead 2 and lead 3 or some pattern like this one, would you like to tell them?
Yes. So there is multiple things that in the literature that you can look at to differentiate, for RCA or a circumflex as a culprit. As an interventionist, sometimes that helps you when you're going into the procedure. But for prognosis, usually, the thing depends on the extensiveness of STEMI of the percentage of ST elevations versus ST depression. But of course, I mean, you can compare if you're having a posterior infarction, think about the circumflex, because that posterior part and the lateral part a lot of times is supplied by obtuse marginals, and it can be a circumflex. But also, if you have a very large dominant RCA, that can also supply the posterior wall. So that can be helpful in certain cases. Lead 2, if it's lead 2 is more, and I think, correct me, Amrish, if lead 2 is more than lead 3, that goes, I think, with the RCA. If lead 2, the ST elevation in lead 2. In this case, the two are almost the same, so it's not helping in that differentiation, sometimes if you're having a high lateral infarction associated with the inferior, also that indicates that the lateral wall is involved, but that goes with the circumflex. So those are the kind of factors that I'm familiar with, but it is for intervention purposes and for the cath purposes, sometimes it is useful to differentiate. But the most important, of course, is you need to define if there's a STEMI or not. In these cases, clearly we have a STEMI. So the next case is.
But we have to say that also, that what happened, this complete heart block and everything, if we open quickly, it can return back to sinus again, because could be temporary ischemia because of the AV node and the SC node. And when you open quickly these arteries, it can no need for pacemaker for this patient in the future. Does not indicate that he will have a pacemaker. So that only put temporary and then can be removed after that. Are you agree?
What you're pointing out, Dr. Bakir, is recently there's a published paper on STEMI patients who are complicated with shock and severe complications. Those patients, if they are treated very, very early, even, your target should be a door to balloon, even 30 minutes or less than an hour. their survival is far better than 2-3 hour delay. So these patients are the most who benefit out of a very early rapid intervention and rapid treatment. So definitely saving lives in this patient is a time issue. So the more such patients, when you see a complicated STEMI, you have to act rapidly. Every minute really counts. Really counts. So 56 female hypertension smoker with a family history. She presents with chest pain, sweating, and walked into an MPCI hospital. And she got a long time to reach to the PCI hospital. So these such patients, usually they are thrombolized. But what do they have? So, so this patient is, if we go systematic, rate, rhythm, and access. So she's sinus. The rate is about 100 or so, 90 to 100, so almost within. So she's more of towards the tachycardic side. And then we go to the axis, which is normal axis, because we have an upright here in AVF and lead one. The QRS complex is more positive. And then, of course, we look at the STs and the intervals. So STs, definitely there is more than 1 millimeter ST elevation involving V1, V2, V3, 4, and none in V5 and 6. But then they have an inferior ST elevation. So there's a combination of inferior and anterior ST elevation.
There is a Q wave, come on. There is a deep Q wave also, yes?
Exactly. So we have a Q waves, and also we have those reciprocal changes involving the lateral. So such patients, when you take them to the cath lab and you open their LAD, most likely the culprit in this patient is the left anterior descending artery.
So if Dr. Abdul Majid, I will just interrupt you for a second. From the audience, mainly the confusion, all on the audience, they agree this is a myocardial infarction. Some in the audience are gravitating towards the idea this is an anterior myocardial infarction. Some people in the audience are gravitating for idea this is inferior posterior myocardial infarction. And one doctor, he picked the right diagnosis, which you are actually alluding what you would find in the angiography. So one Dr. Mustafa, he put actually in the right way. So would you please tell to the audience how we can reconcile this ECG? Obviously, if this is inferior myocardial infarction, we are thinking of RC and the circumflex artery. If this anterior wall, we are thinking the LAD. What type of situation can give rise to an infarction pattern in both the leads?
Thanks, Amrish.
Before you answer, Zubayd,
yes.
Which mean the dominant left system from where the right or coming from, the posterior descending coming from where?
So here, such an anatomy, what happens is you have the LAD supplies the anterior wall. That's the typical. And then you have, in some people, you have the LAD supplies the anterior wall. It goes all the way down to the apex and it wraps, we call it wraparound LAD. And then it goes to the inferior wall and it supplies part of the inferior wall also. And sometimes it can extend all the way down to the inferior, to most of the inferior wall. So if this LAD is occluded proximally, the anterior wall is going to suffer and the inferior wall is going to suffer because we call it a wraparound LAD. It's a large LAD, and unfortunately, it gives a massive infarction. And some of these patients, they present with shock because it is an anterior and it's an inferior STEMI, as some of our colleagues in the chat box on our audience picked it up. So this is an anterior inferior ST elevation myocardial infarction, and obviously posterior I would question, because posterior usually you get a dominant R wave in V1, V2, and you get ST depression down in those leads, or V1, V2, sorry. You get ST depression with dominant R waves. In this case, no, we have already almost like a Qs in the anterior leads. So definitely the plan, if there is an evidence of an RV infarction, you need to treat this patient. Mostly, I think he doesn't have RV, It's mostly anterior, inferior, and he needs to be transferred as soon as possible to a primary PCI site. Of course, in 4 hours, I would thrombolize and then transfer him rapidly. Be sure that.
High peak T wave can carry any prognostic value, Dr. Zubaidi or Dr. Amrish? The high peak T wave like this, can any prognostic value this indicate bad situation or no indication? What do you think, Dr. Amrish?
So what is the genesis of the tall peak T wave in the patterns with the acute developing myocardial necrosis? So the genesis, if you see from the ECG linked to my talk, it is a localized hyperkalemia which occurs at the cellular level at the site of myocyte damage. So the very fact that in spite there's a Q wave, the T waves are peaked, this tells me that the ischemia is ongoing, and this patient can be rapidly traced to the reperfusion strategy, which anyway we are doing it, but this patient there's a more rapidity because in spite of Q waves, which you normally do Q waves follow up in 4 to 6 hours time, but there is a still ongoing myocardial necrosis. So this indicates a localized hyperkalemia at the site.
Yeah. And actually another point, Amrish, to add is there's some papers that looked at the number of ST or the collection of ST segment elevation in the 12 lead or deviation, not elevation, deviation. So for example, here we have 5 millimeter, again, 3 millimeter, maybe a couple of millimeter here, and then in V4, and then down here. So if you add all of that, that has a prognostic value. So the more ST deviation you're having on the ECG in an acute coronary syndrome, usually it indicates a bad outcome. And of course, that tells you that you have a more responsibility in triaging these patients rapidly, transfer them, and treat them early. So I'll move to the next message. So I'm trying after each case to give a message. So we talk about universal definition, talk about localization, talk about complications of identifying complications on 12 lead. Now, this is from the European Society of Cardiology guidelines, and the message is 12 lead ECG recording and interpretation is indicated as soon as possible at the point of first medical contact with a maximum target delay of 10 minutes. So what does that mean? You need to do an ECG. If someone comes to your hospital or your emergency or your clinic or your primary health care with chest pain or with pain in the neck, epigastric pain, shoulder pain, those patients, they deserve an ECG within 10 minutes. And of course, you need to read that ECG, not just doing the ECG. It's doing the ECG and reading it, so you can pick those patients up. Of course, ECG monitoring. If you find a STEMI, this is another very important point. Is if you diagnose a STEMI, you need to connect your patient to a monitor, because these patients at risk of VF or different type of arrhythmia. Monitor will help you recognize those patients. And then, of course, right-sided leads and posterior leads are very important. A routine blood sampling for serum biomarkers is indicated as soon as possible in the acute phase, but should not delay reperfusion treatment. We emphasized on this message, and we're saying it again. It's important that you do the troponin. You need to do them, but they should not delay the care, should not delay transferring this patient for reperfusion treatment. So let's move to another case. Male, 39, hypertensive smoker with family history, strong family history of premature cardiac disease. Very important you ask about that, this risk factor, because it does help you. He presents with chest pain, sweating, and thrombolized. He was thrombolized and he was transferred to your site. And so when you receive a patient post-thrombolysis, you have to do a 12-lead ECG. And this is ECG. So what do you see? So again, here we don't have the tracing, but I think we can pick a tracing from one of the...
Everybody have to do rate, rhythm, axis, interval. Don't be attracted by the ST segment only.
Exactly. So diagnosis is clear, but go systematic. So we're not seeing an interaction from our colleagues, the audience, but I can go with that. So this is a sinus. You can see P waves. You can see P waves. PR interval is okay. So the rate again is 1, 2, 3, about 100. and the intervals are okay. The axis is okay, is normal axis, and by looking at one in AVF QRS complex. And of course, there's ST elevation more involving lead 3 than lead 2. And the rate is, someone says 75. I would disagree with that. Maybe it's about 100 because there's 3 large boxes. And then there's ST elevation in V1 and V2. And for those people who those who are interested or asked about RV infarction, this is suggestive of RV infarction. And to confirm it, you need to do what we call a right-sided lead. So there's inferior ST elevation involving more lead 3 than lead 2, indicating maybe this is the right coronary artery.
What about the reciprocal exchange to bed?
And then we have a reciprocal change involving the lateral leads. You're right. So in conclusion, sinus rhythm, normal axis, intervals are okay, inferior ST elevation, complicated with RV infarction. Any other points you guys want to add to me?
I add something. Look to this ECG inferior, but tachycardia here, while the other one inferior with bradycardia. So
Yes.
when you find inferior with tachycardia, you have to look about the right ventricular infarction because of the volume now is the story, because this patient need the heart rate to be increased. You get my point, Dubedi? Amrish, what do you say?
Yes. Yeah, and obviously the ECG got ST elevation in lead 3 more than lead 2, and this indicates the right coronary artery lesion. And second thing is that there is a reciprocal changes in 1 and AVL, and there's evidence of right ventricular infarction. So the point of infarction is very certainly in the proximal right coronary artery before the origin of RV branch. So the localization is very clear. And like you said, the hemodynamic management depends on the blood pressure. If the man blood pressure is normal, you would just give him fluids to continue. If he's hypertensive, then you will first load with the fluids. The rhythm is sinus, so there is no AVC synchrony. The rate is reasonable. It's not bradycardic, not tachycardic, so the rate cannot be explained. So you have to focus on this multiple areas of therapeutic interventions regarding apart from interventions in this patient.
Excellent. I'll just show our audience and some people who are not familiar with RV infarction. So in inferior STEMI, RV infarction is suggested by the presence of ST elevation in V1. So we saw it in our case. The only standard ECG lead that looks directly at the right ventricle. ST elevation in lead 3 more than lead 2 also is makes you suspicious. So what you do is if you're the one who's doing the ECG, or if you have a technologist or a nurse who's doing it, then you can ask them for right-sided leads, and this demonstrates the right-sided lead. Usually, our standard leads are here, if you can see, on the left side, but in right-sided leads, usually you do the same leads, but on the right side of the chest, and that will demonstrate for you an RV infarction. This is by ECG. Of course, you can do an echocardiogram, and that will reveal it. Of course, also clinical diagnosis is very important, because in this patient, you'll find hypotension, and sometimes they don't have a pulmonary edema. So if they're hypotensive and their lungs are clear, think about either a pericardial effusion or pericardium or right ventricular infarction. Of course, the JVP is going to be high also in these patients. So RV infarction can be a clinical diagnosis, ECG diagnosis, and echo diagnosis. And the treatment, as pointed out by my colleagues, fluids, avoid nitrates. Very important message. Nitrates. If you have someone with the right or with inferior infarction, you give him sublingual nitrates and he drops his pressure, think about RV infarction. So nitrates can lead to drop in the pressure. Prognosis usually is acutely indicates a bad prognosis, but usually these patients, they recover. RV infarction most of the time recovers compared to LV. Let's move to the next case. I don't know if you guys have any comment to that, to the prognosis and the treatment?
No, it's okay, but as we said, that we have to look with inferior, respect the tachycardia with inferior MI. This is very important to respect, because you have to think about right ventricular infarction, as Dr. Zubeidi said.
Okay. So the next case, so 44 male, okay, smoker dyslipidemia, chest pain, sweating. He had a coronary angiography 3 years back. So that tells you you have to be suspicious. So that's his ECG. Okay, not impressive. So he comes to your emergency. He got risk factors. He had an angio, had a PCI a few years back, and now he comes with a chest pain. His ECG is not very impressive. So let's go systematic. So sinus rhythm, okay, and the heart rate is about 75 maybe. You know, I can't see axis is normal. Looking at lead 1 in AVF. The intervals are okay. Looking at the intervals, the QRS, PR, and QT. So sinus rhythm, normal axis, normal rate, normal intervals. ST segments, nothing major, maybe some sagging ST here, but not very impressive. So what do you do? I mean, I have a message for this ECG. I want to convey it to you. So the key thing in such patients, the pre-test likelihood is very high. Someone who had a PCI before, someone got multiple risk factors, has a chest pain. Normal ECG or silent ECG should not let you or reassure you. You should observe these patients and keep him till for observation. And that's what happened to these patients. So, you know, later on, these patients had chest pain and the ECG became totally different. So what do we see on this ECG now? Rate is still almost the same.
Rhythm axis interval. This is very important.
So still in sinus rhythm, the rate is still almost the same. The axis is the same, but now we're having ST elevation involving lead 3 AVF, lead 2, and we're having ST depression involving the anterior leads as a reciprocal changes. Lead 1 AVL is becoming inverted.
And we consider this reciprocal changing, or we have to also think about posterior MI.
Exactly. So there is an inferior posterior infarction now evolved, you know, after that silent ECG. So the message here is, you know, if you're having a normal ECG in someone who you suspect that they have something, keep them for observation. Repeat the ECG. And there is a lot of data that talks about repeating ECG increases your sensitivity and your chance of diagnosing an acute coronary syndrome. So this comes out of the guideline, this paragraph, ST segment depression or elevation or T-wave inversion increase the likelihood that the discomfort is due to angina or ACS. However, the lack of these findings should not rule out angina as a cause of the chest discomfort. So a normal ECG or no deviation should not rule out. The initial ECG has a sensitivity of only 20 to 60%. So, you know, so you have to ensure that you repeat the ECG to improve your sensitivity. Of course, your troponin will help you again. Another case, 48 male dyslipidemia smoker, family history, presents with chest pain and palpitation. That's the ECG. A lot of drama there. So, Sharif, can you help me here?
Yeah, we have to, again, rate, rhythm, axis, entry. So the rate, what is the rate? If you calculate the big square, we'll find that 1, 2, 3, and yeah, and it looks like 88 something, 90 something like that. And then axis, rate, rhythm is regular. Every P wave followed by QRS complex.
Yes.
Axis, it looks like a normal axis.
Yes.
Interval, it is now looks like a normal interval, but because of the QRS complex is ST segment elevation distort the shape. But if you calculate it correctly, there is no QRS complex. I mean, normal. The interval are normal, and the PR interval, QR interval are looks normal. And also, now we'll go to the ST segment. Where is the ST segment? You have look to lead 1 and look to lead 2 and look to AVL and also we have AVF, and then go to the ST segment in V1, V2, V3, and then go to V6, you will find ST segment elevation. So from the intervention point of view, Dr. Zubaidi, what is the coronary anatomy for this?
I think most likely this is the circumflex that's occluded. I mean, we're having you know, ST elevation more on lead 2. We're having a posterior suggestive, sorry, ST changes suggestive of posterior infarction and lateral infarction. So posterior, lateral, and inferior, and that is most likely this is a left circumflex. And our colleagues here in the chat box,
Yes.
I am enjoying it. You know, I mean, I think we have a lot of interaction, which is great. You know.
So Dr. Abdul Majid, you showed many ECGs of similar pattern, but this ECG is a little bit different from the previous ECG. The thing is that in the previous ECG, the inferior wall ST elevation was far more than the ST segment depression in V1, V2, V3. In this patient, the most prominent pathology is the significant ST segment depression in V1, V2, V3. And sometimes, I will tell to the audience, if you're not clear, just invert the ECG and put the top part of the ECG at the bottom, and you will find that this will look like a clear ST elevation in V1, V2, V3. So in this patient, the primary pathology is the ST elevation MI at the posterior wall territory, along with this lateral myocardial infarction because the ST elevation in one AVL. And you will notice that the ST segment elevation in the inferior wall leads is much more smaller in magnitude that the ST elevation in the posterior wall leads. And the ST elevation of posterior wall is equal to ST elevation of the surface, the ST depression surface ECG. So the primary pathology, like you said, that you will find a circumflex lesion, and the circumflex lesion is mainly because of posterior lateral myocardial infarction.
Dr. Amrish, one of the audience asking, what about left bundle? He said, is there any left bundle in this?
No. The left bundle is decided by the QRS complex width, but here the QRS complex width, if you look at V4, yes, V5, is not there at all. So
as we said from the beginning, it looks like because of the distorted P-wave ST segment, give you impression that, but if you look, you'll find the J point, and look to you'll find the QRS complex within the normal range.
Exactly. And I think, you know, such patients, someone asked about posterior leads, and I think, you know, you can confirm that with the posterior leads, the posterior infarction. Someone asked about, of course, the left bundle, and someone talked about late presentation. I don't think, I don't know why would someone say it's a late, you know.
There is no Q waves. There is no Q waves at all.
Yeah.
So it's still.
So it depends on of course, the duration of the chest pain, and of course the recovery of the ventricle later on. That you can tell if this patient. Dr. Sharif insists on systematic approach. I think it is fair. Yes, I agree. Okay, we'll go to the next. So that's the message I think we're trying to convey. This is the posterior lead. So if you suspect a posterior infarction, you can ask for those leads, and this is where they're located. This is up here is the scapula, so the back of the patient on the left side. So you ask your technologist or your nurse, or if you're the one who's doing the ECG, to record those leads in the posterior part of the patient below the scapula, and they will give you ST depression if there is, ST elevation if there is a posterior infarction. And how do you suspect the posterior infarction? We saw it on the previous ECG, horizontal ST depression, upright T waves, and then a dominant R waves, R more than S in lead V1 and lead and V2. I hope this is clear. Okay, another case. Female, 53, multiple risk factors, atrial fibrillation. Comes with an epigastric pain, dyspnea. She presents to primary healthcare. So this is a primary clinic, not an emergency department. So this is her ECG. What's happening here? A lot of posterior. Okay. So rate, rhythm, axis. So the rate here is, I guess it's difficult to quantify because the rhythm is irregular. So the rhythm here is irregular, suggestive of atrial fibrillation, but the rate is somewhere around 100. And the way I would calculate the rate here, Dr. Sharif Bakir, just for the sake of interaction.
You have to take amount of number of beats and to calculate the between each beat and whatever the number, if you take 6, 5, 10, whatever, and then to divide on the number. To make it much simpler for you. And this is the way to calculate. But by rapid, you have to look what is the widest here. Like for example, in the lead 2, the last one, it is the 2 widest, and in the middle it is shortest. Based on that, you can divide it. But according to the irregular wrist, you have to take number of beats and to calculate the distance between each beat, and then how much the number you take, and then you will divide it on both. If you take 6 beats, 10 beats, whatever, but you take each beat separate.
Yes. So this case, probably the rate is about 100 plus maybe. It's irregular. Obviously, it's atrial fibrillation. The axis is normal. And in terms of infarction, we saw in the previous ECG, there is ST depression involving the lead V1, V2, V3. And as mentioned earlier by Dr. Amrish, if you flip this ECG, you'll see an ST elevation. And of course, in the inferior leads, it's not so dramatic that the ST changes, but laterally there is ST elevation. So there's a lateral and there is a posterior infarction in this ECG. Okay, so then again, complications of MI are very important. ECG is, of course, clinical recognition or clinical assessment of the patient is very important, but ECG can help you. And arrhythmias are you can see them, they're very common with myocardial infarction. We see accelerated rhythms, mainly with the reperfusion. We see the bradies that we talked earlier. We see non-sustained VTs. We see sinus tachy, AFib, high degree AV block, and VT and VF. And that's why it's very, very important that you put your patient on monitor. So once you suspect an acute coronary syndrome, an acute MI, you need to connect the patient to a monitor because they are at risk of all these arrhythmias. And if you don't recognize the arrhythmia early, the patient can go down the slope, and it may be difficult to retrieve them or get them back. 9th case, male, 56, multiple risk factors, presents with chest pain and dyspnea. That's the ECG. Another ugly ECG. Any tick? So I can't see a P waves, Dr. Sharif, if I'm gonna go systematic here.
Great, can you comment, Amrish, Dr. Amrish?
So there's no, there's some irregularity.
This is the ECG which some people commented before. They are asking if this
Yes.
is a left-handed branch block. So
Exactly.
this patient, you can see obviously the gross thing which first thing your eyes goes attention is that how broad is the QRS complex. It is certainly not narrow, it is broad. Then we try to look at the P waves, we don't see any P waves. So it appears that this man, but there is some component of the initial part of the ECG, maybe from the second beat, second, third, fourth beat appears to be kind of regular. Then there is a small amount of regular tachycardia. So there's a bradycardia in the initial part, which with the absence P wave. Then there's a tachycardia, but the QRS complexes are wide. So this is a left-handed branch block, and we can say that I think I will put this diagnosis of ST elevation MI in the presence of left-handed branch.
Yes, I agree with you. I mean, I think this patient got a what looks like AV, some sort of an AV block or complete AV block, or it's a or arrhythmia, atrial fibrillation with a high a grade AV block because the QRS complex is somehow irregular here. But definitely this is a complication of an anterior ST elevation MI presenting as a left bundle branch block. And this patient needs to be sent to the cath lab very early. This is his ECG 1 year back. So obviously this is a new left bundle branch block. And the message here is when you are treating, when you face an ECG with a left bundle branch block, try to see if there's an old ECG. If you can't, there's nothing, if you don't have that luxury, or you cannot find an old ECG to compare, then you treat the left bundle branch block in the presence of chest pain as a new STEMI, as a new left bundle branch block, and you treat it as a STEMI. So atypical ECG. So you have to be familiar with these findings again. Atypical ECG findings or presentations. So presence of left bundle branch block. This is the Barbosa criteria, and you should treat it as a STEMI. Presence of right bundle may confound the diagnosis of STEMI, but you have to be most of the time not, But left bundle, definitely you treat it as a STEMI. Sorry, someone who has a pacemaker, usually it's difficult to diagnose STEMI or acute MI, and your level of suspicion should be high, and you may have to use echo. What do you think, Sharif or Amrish? Someone with a paced rhythm, how would you approach them?
I think this is something you have to do.
It's a difficult scenario, if you're having someone paced, but go ahead, please.
So your question is?
My question is, with someone who have an ECG and he has a paced rhythm.
Yeah.
What I was saying is diagnosing MI in this type of patients is difficult. So your level of suspicion should be high. If someone is having severe chest pain, you may have to do an echo and look at, if the ECG is not helping you.
Synchrony because of the pacemaker. But you cannot only, as we said before, if somebody came with left bundle branch block without any previous ECG to compare, treat as acute myocardial infarction. What do you think?
Yes, I would treat them as an acute MI till proven otherwise. Paced rhythm is one of the cases, one of the scenarios that ECG becomes of a less help. And so you have to use other tools to help you in the diagnosis, clinical and imaging tools. Let's move. So of course, posterior, we talked about it. Left main ST depression in more than 1 millimeter in 8 or more surface leads, and I have an ECG to show you later on. It should make you suspect a left main or severe perivascular disease. ST elevation in AVR or V1 may suggest the left main disease. So usually put that in your mind. ST elevation in AVR. If you're having a lot of diffuse ST depression across the 12 lead, think about 3 vessel and left main. And then, of course, we talked about the left bundle and the paced rhythm. So another case, 45 male presents with chest pain. He called the EMS and this is his ECG. So what do we have? Systematic. So sinus rate is about 90 to 100. I mean, it's more than 3 large boxes between the 2 consecutive QRS. It's regular. Access is almost normal access. And here it's more positive than negative. Here it's all positive. And then we're having what looks like a right bundle with ST elevation involving the anterior leads. Of course, there's some ST depression here in the inferior leads. Any takes?
I think it is the important is also we have not to ignore that there is a Q wave, and the Q wave is deep. Yes. And what is the presentation? So this is very important. because we have.
So systematically, this is a sinus rhythm with a rate of about 100, and axis is normal. We have intervals are okay, but there is an ST elevation involving the anterior leads with a pattern of right bundle branch block. So I would treat these patients as an anterior STEMI till proven otherwise. You agree with that? Or do you have any extra comments? Both Dr. Sharif and Dr.
Also, we have to respect the presence of the Q wave.
Yes, there's a key two ways, of course, in the anterior leads. So so that's the patient. So ST elevation in the setting of right bundle, the ECG criteria for right bundle branch block includes the following: QRS duration greater than 120 milliseconds, which we saw in this patient. Okay, and so QRS duration, that's the QRS from here all the way to here. So that's the QRS duration. So it's more than 120 milliseconds. 120 milliseconds on the ECG is more than 3 small squares. RSR pattern, and then unlike in the presence of left bundle, myocardial ischemia and infarction can be detected on ECG when a right bundle is present. So most of the time, right bundle is does not obscure the STEMI, the ST elevation. So if you see ST elevation in the presence of right bundle, you get to treat it as an ST elevation. Of course, there's other differential like Brugada and other diagnoses, but you should treat it as a STEMI till proven otherwise. Now we'll go to the last case, and then we have a few drill before we get to Dr. Amrish's talk. Male 42, chest pain. You do an ECG, and that's his ECG. Okay, so sorry. So that's his ECG. So we have, if you go systematic, sinus. Okay, the rate is, let's take here, 1, 2, 3, 3 large boxes, so about 100 beats per minute, plus minus. And then we have an axis that is positive in lead 1 and equivocal in AVF. What do you think about that, Dr. Bakir?
I am waiting for something very important at the end, but let you finish. I will let you do.
Sure. Yeah. So the axis is still within normal. It's more maybe towards a the right. Or the left. So the ST elevation in lead 1 AVL, and then involving the anterior. So there's an anterior lateral ST elevation involved in this patient, but still he's maintaining sinus rhythm and he does not have any arrhythmias. So he was taken for it to the cath lab, and obviously you can see.
Another important point, Zubaidi, if you look to V1, V2, V3, there is a failure of progression of the R wave.
Yes.
Look, there's no R wave, a small R wave, and then suddenly abrupt R wave in V4.
Yes.
So what is the differential diagnosis? Something like that. We have to understand this is a deep, you have small r, and deep is V1, V2, V3. And then abrupt, sudden abrupt. So they have many differential diagnoses. Sometimes it could be, this patient could be hypertensive, could be left ventricle, and there are many cases to explain the failure of progression of the R wave and this deep S wave. Okay,
right.
Go.
Okay, so I think that's the that's what we have so far on the ECGs. Now, if we have time, I know shortly we have to move because we're finishing at 8, and there's a talk for Dr. Amrish. Amrish, how long is your talk? He's not
Sorry,
there.
I muted. Around 20 minutes. 15
okay.
minutes.
So I got another few ECGs just to challenge our colleagues. We'll try to go fast on it, and I'm just going to do only maybe 10 tracings, if that's okay. Okay, blah, blah. Can you see it?
Yes.
Okay. So the way we're going to do this is going to go quick, and we'll try to. I don't know if our colleagues from the event can help us in having like an MCQ thing, where we share the our audience can have a look at. Sorry, can pick one of these. Or we can just do the same as we did before, if that's not possible. They promised me that they can do. So this is a 48-year-old smoker. I think I got this patient a couple of days back, 22nd of October, yesterday. So presents with this ECG. What does it show? Can we give the audience ABCD icon?
Most of them, most of them, they wrote C.
Okay, C. So yeah, so this is a posterior infarction. So that's great. I mean, we explained this early, and we said in such patients you will do a posterior leads. So just for those who didn't get it, we have a dominant R wave in V1, V2, and V3, and there's ST depression. So this patient has an isolated posterior infarction. As you can see in this ECG here, the V4, V5, V6 are posterior. It's just they're not labeled right, but those are the posterior recording, and there's ST elevation. Is it clear? So we recorded the posterior. So this is the same patient, but recording posterior leads, and as you can see, there is ST elevation there. Another patient, 37-year-old smoker, came to the emergency yesterday or day before with this ECG. Anything abnormal? It's almost within normal. Some sagging ST depression, if you want to call it. So some ST depression, I would call almost, it can be passed as normal, or some sagging ST involving the inferior and the lateral. This patient came yesterday, or day before, in the morning at 8 o'clock. And then 2-3 hours later, this is his ECG. Massive anterior MI. The message again, normal ECG or not so impressive ECG in the presence of chest pain and risk factors should not exclude acute coronary syndrome. You should keep thinking, repeat the ECG. That will help increasing your sensitivity and specificity of the diagnosis. So repeating ECG is very important in the setting of chest pain. 24-year-old comes with chest pain. Diagnosis. Okay. See. It's a lot of B's, a lot of B's, a lot of B's in the chat box. So the chat box, most of the people are B. So yes, so this diagnosis is anterior ST elevation. I can't see other than the B. So anterior ST elevation, you can see it here. And then also there's a lateral component. Of course, the sinus, the axis is okay, but there's ST elevation lead 1, lead AVL, and then V2 and V3.
And also look to any reciprocal.
Yes, so there is reciprocal changes. Thanks, Dr. Bakir, and involving lead 3 and AVF.
And this is very important because this is 24 years old, young.
Yes, we see a lot of young now. We see, Amrish, how do you see in Fujairah?
We don't see that much in Fujairah, luckily for us. I mean, I'm just thinking in this 24 years old man, would you like to consider some alternative diagnosis like pericarditis? How would you distinguish this
Yeah.
ECG from the ECG of pericarditis?
The
Yeah.
question of pericarditis have been raised by Dr. Amrish, but the presence of reciprocal change, as we said before, this is will make that, yeah, of course, young, you have to find why, but the presence of reciprocal change leads you to think more for the infarction than the pericarditis. Yes. Because usually we don't find pericarditis in the reciprocal, and you will find multiple leads, usually all the leads. There is no distribution to any coronary anatomy.
Yes.
Yeah,
The pericarditis disease is characterized by infarct related distribution of ST elevation, mostly generalized, and typically more ST segment depression in AVR and V1, and sometimes you can get a PR segment depression, which obviously all three components are lacking in this ECG. So this
but the question is,
more likely diagnosis.
Amrish, do you take him to the cath lab or not?
No, in this patient, the first key will be an echocardiogram baseline, because you have to exclude many conditions. And a young man, it will just take few minutes. And if you confirm there is a volumetric abnormalities, then you have clinched the diagnosis. Either way, this patient, if the cath lab facility is available, the cath lab is where the angiography is very important, particularly from diagnostic point of view. Because if the angiograms are normal, then you start looking for myocarditis and other possibilities.
What you have been raised, Dr. Amrish, is very, very important, because now you are stuck with young, we're stuck with ECG, with some mix between MI and the mix between pericarditis, and you have some reciprocal change. So now you are in confusion state. So as he said, the echo is just a quick look. We don't want to do complete echo, just to put for the left ventricular function to see if there is any wall motion abnormality or not. And this is can let you to wait a little bit before taking to the cath lab, or you can, depending on the situation of the patient. What do you think, Zubaidi?
Yes, definitely. I mean, an echocardiogram in the emergency is very useful tool if you can do it quickly, and it's not going to delay the care of the patient, and it can help in differentiating if this is especially in in acute pericarditis.
Now we are seeing young age came with infarction. Why?
Yeah, we looked at our registry, and one of our fellows looked at that at the registry. I think about they looked about 300 plus patients, young STEMIs, and 350 less than 35 years old from from 6,000 patients. So a significant number. I mean, here, of course, our population is skewed population, a lot of young people, but definitely we see young. Of course, 24 is very young. I mean, we see 30 plus minus. I'm not saying common, but it is.
Yes.
We see it. 29 chest pain comes with this ECG. Again, the same thing, the same message. I mean, here echo is very helpful, and as you can see, you're having sinus rhythm. The axis is normal. The rate is almost within normal limit, a bit more on the higher side, and then you're having ST elevation involving the anterior leads, maybe some ST elevation here, and again in the inferior leads. So differential diagnosis of ST elevation is myocardial infarction, pericarditis, repolarization, and others. So echo, as stated,
PR interval depression in lead 2.
In lead 2, you are talking about here.
Lead 2 down in the
here, yes.
Interval. It is depressed.
Yes.
I think it's isoelectric or what? See, the one thing you can highlight to the audience is that when you take a segment, what is the isoelectric segment of the heart? The isoelectric segment of the heart is a TPA segment. So if you take from the TPA segment, the PR segment looks isoelectric. It's actually the pattern of early correlation in lead 2-3 AVF, which makes you think that this patient may have an PR segment depression. This is what I thought it is.
Yes. So this ECG is not an easy ECG, to be honest with you. And an echo in such patients can help you differentiate if this is an infarction, where in the echo, the wall will be hypokinesis. or akinetic, versus if it's a pericarditis, there will be no regional wall abnormality, while you may see a fluid around the heart if it's a pericarditis. Interestingly, this patient, I know the case, and he had an anterior MI. So sometimes it can be surprising. When I saw this ECG initially, I thought it was more of a pericarditis, considering the young age, but he ended having an infarction. Again, and we'll stop here, 67 female with palpitation. So sinus rhythm, I think it's tachycardic. The rate is more than 100 beats per minute. The axis, lead 1 is positive, AVF is negative, so that's a left axis. And then we have a right bundle branch block. So we have we call bifascicular block because there's a right bundle and then there's a left axis. Left axis indicates a left posterior block with the right bundle branch block. So sinus rhythm with the bifascicular block. And important thing here is AVR, there is a ST elevation that may suggest an left main disease. So this patient, I would treat them. Of course, there's no clear ST elevation here, but I would consider this patient as a high-risk patient, and I will do an early angiogram as soon as possible, as early as possible. So, I think just for the sake of time, we have more tracing that we can go over, but unfortunately, we are also under pressure of time. So I think we'll stop with the tracing, and we have a talk, an industry talk by Dr. Amrish. So we'll conclude our ECG symposium and our ECG reading. Thanks to Dr. Sharif Bakir. Thanks to Dr. Amrish for your help during the discussion. Thanks to our colleagues, the attendees, they have been very, very interactive. I don't know if they can see the chat box, but the chat box is very full of comments and interaction. I like this. We thank you for that, and I hope this was very useful to you, and I hope it does have an impact on the care of your patient. So we'll move to the final part of this session, which is hyperkalemia, clinical implications and management. Dr. Amrish Agrawal is a senior consultant cardiologist and associate professor of medicine in Fujairah Hospital. Dr. Amrish, the floor is yours.
Thank you very much. It was really an excellent, I will say rather a roller coaster of feelings and the mental abilities which have been taxed by the previous two talks. Dr. Juvedi took excellently the different scenarios of different associations with the inferior myocardial infarction, and even one case which looked like a hyperkalemia, but not at the global level, at the cellular level. So today we are going to talk about a condition which is explicitly associated with the cardiology conditions, and it's one condition which the cardiologists are very much concerned about is the potassium hemostasis in the human body. The thing is that the potassium is the most abundant intracellular cation, but outside the cells, the potassium concentration, the body regulates in a very tight range between 3.5 to 5 millicuries per liter. The electrical stability of the heart is very, very sensitive to the extracellular concentration because the potassium is responsible for the action potential maintenance across the cell membrane, and the disturbance in the potassium hemostasis and the consequent hyperkalemia and hypokalemia can be very, very hazardous to the heart. We have a lot of therapies which has come in the region for the cardio protection, renal protections, and unfortunately, all these therapies, they promote potassium retention and hyperkalemia, which can prevent effective guideline-derived medical therapies because we are afraid, or physicians are afraid to cause hyperkalemia in these patients. One of the therapies which is very closely linked to the potassium hemostasis is a heart failure. The reason are multiple, because the drug treatment of the heart failure typically, as has been put in the European Society guidelines released few months back, rely on four classes of the drug. The first class on the left pane is the RAS inhibitors, so they include ACE inhibitors, ARNI, and the ARBs, then consist of beta blockers, MRA, and the SGLT inhibitors. The guidelines say very clearly that all these therapies which are used in the treatment of heart failure should be up titrated to what doses, to the dose which have been found effective in the clinical trials. Those doses are not small, and I can tell you in the heart failure clinic, very few patients are reaching this full dose. Most of the patients are suboptimal doses, and maximum tolerated dose or up titrated to the dose used in the clinical trial. For example, the historical trials have shown very, very clearly when you give the patient ACE inhibitors or the ARB, you actually cause nearly 15 to 18% improvement in the cardiovascular endpoint as compared to the placebo. And the new wonder drug, which came in 2015, which we call as sacubitril/valsartan combination, so also called as ARNI, causes further 20% additional advantage over baseline therapy of ACE inhibitor. So we can say nearly it causes 35 to 40% further improvement in the patient with heart failure as compared to placebo. Addition of mineralocorticoid receptor antagonists to the background of ACE inhibitor and ARB can cause further reduction in the cardiovascular endpoints such as heart failure or cardiovascular death, and actually causes better survival improvement as was shown in the clinical pivotal trials of spironolactone and eprinolone. So overall further reduction of 30% mortality. So if you take the sum total of all the therapies which affect the RAS inhibitors, which can cause hyperkalemia, overall benefit which can be seen ranges to the benefit of 60 to 70% improvement in the mortality. And this is from the network meta-analysis of 57 randomized clinical trials, which were published up to 2015. So this is before the introduction of SGLT2 inhibitors, and SGLT inhibitors make it further improvement by nearly 20%. So it appears that we as a cardiologist have done a lot in the management of heart failure, and we are actually able to conquer heart failure in our clinical practice. Like I told you before, all these therapies which I discussed with you, the ARNIs, MRAs, and to some extent the beta blockers, by interfering with the renin-angiotensin system causes hyperkalemia. So all these things will cause portal retention, and this is our problem in the clinical practice, the fear of hyperkalemia. And in the sub-patient who develop hyperkalemia, the first thing is to be taken off is the indication, what is the RAS inhibitors in the population. So in the clinical trials, don't really tell us the full extent of the problems. For example, in the clinical trials of RAS, emphasis, and ephesis, the typical hyperkalemia, which is reported by 2% to 5%. Now, these clinical trials include patients which are not the patients which come to us in the clinical practice. They are more stable patients. In the real life, what we see, you and I see, we see in the clinic, the degree of hyperkalemia is far more frequent. It can range to as high as 10% in the population. The another thing about hyperkalemia is the predilection for the second episode and the third episode. So in the big database from Denmark, which included nearly 31,000 patients, the people who have hyperkalemia, they found nearly 40% of the first episode occur as the first episode, and this occurred typically nearly 4 months after initiation of therapy. However, subsequent episodes in these patients become more frequent and more rapid. So you can see that out of the 40% patients who develop the first episode, nearly 43 patients develop a second episode, 50% develop a third episode. So the propensity to develop hyperkalemia after developing the first episodes become more frequent, and that is why these therapies can have medical legal implications for the treating doctor. Once the person develops a chronic hyperkalemia, there are very strong chances of hyperkalemia-related hospitalization, and for the patients which can be seen in the population across what conditions. For example, you can see the right-handed pain in a typical patients who develop hyperkalemia in the patients with heart failure. The amount of hospitalizations which are related to hyperkalemia is nearly the same what is seen for the patient of hospitalization due to any cardiovascular reason. So one of the big reasons for admissions to the patient with heart failure is hyperkalemia. And there are so many instances which you can relate, and I can also relate. The patient admitted to the hospital, you discover hyperkalemia, and the patient has been taken totally off board all type of RAS inhibitors. So the mortality also increases with hyperkalemia. This is the This is the U-shaped relationship between the potassium level and the cumulative probability of the mortality. And you can see the sweet spot in which the mortality, the nadir, is between 3.5 to 5 milliequivalents. On the lower than 3.5, which in the range of hypokalemia, also worse than the mortality. And the potassium more than 5 causes linear increase in the mortality over time. This mortality for the each level of potassium level differs by the underlying risk factors. So the highest mortality for the level of potassium, for each level of potassium, is for the population who are having the culmination of typical factors which makes the patient prone, which is kidney disease, heart failure, and the diabetes. Since this, we are talking about the ECG master class. So in this symposium, we should try to link, see what is the relationship between the high potassium ion and the heart. The thing is that extracellular potassium, when we increase to a certain level, causes reduction in the myocardial excitability with the depression in the both pacemakers and the conducting tissue. Other hand, hypokalemia makes the conducting tissue and the myocardium more excitable, so you have more PVCs, ventricular tachycardia. As the potassium goes over critical levels, you will find there is a suppression of impulse generation by the SA node and the reduced conduction by the AV node and the His-Purkinje system, resulting in bradycardia, conduction blocks, and ultimately sudden cardiac death which can occur. So how is the pattern which can be seen in the electrocardiogram in the patient with hypokalemia? This is a very, very nice diagram which can explain hypokalemia makes the T wave very much tall and tented. And this is the pattern of the hyperacute changes which you saw in some ECGs shown by Dr. Juvedi, that the one of the earliest pattern which you can see in the patient with myocardial infarction is localized hyperkalemia because of tissue damage, and this gives rise to the tall peak T wave. As the potassium level goes more, you will find there's a broadening of the Keras complex. There is a diminution of the P wave. So overall, cardiac conduction and the excitability takes a downturn as the potassium level increase. This response is a graded response. So you will find at the lower level, which is probably 6, you can find just a peak T wave. And as the potassium level goes up, so 7, 7.5, you'll find broadening of the Keras complexes, thickening of the T wave. And this is the type of pattern of some patients who are hemodialysis and they miss their hemodialysis 1 session and 2 sessions. And they come typically in the hospital with a pulmonary edema and a severe hypokalemia. And you can have this type of patterns. Recognition of these patterns are very important because the treatment of this patient is the emergent treatment of acute hyperkalemia. But today's talk, we are going to focus on chronic hyperkalemia. Once the person develops hyperkalemia, it's got implications for the therapeutic management of the patients. Typically, all we are doctors, we are afraid that we will do harm to the patient. So we will be on the side of cautions. We may see a patient at the clinic, patient may not come to us. So the studies are shown globally all over, whatever the level of potassium, whether you take mild hypokalemia or you take moderate to severe hypokalemia, once you develop hypokalemia in the population, there is down titration or discontinuation of guideline-mediated RAS inhibitions in nearly 50% of patients. So you can say that only few patients will continue the same treatment, and most of the physicians, including myself and you and other colleagues also, they will decrease the dose of RAS inhibition, or some patients, they will even remove the total RAS inhibitions in this population. This downgradation of the RAS inhibition has got implications. So once you stop the RAS inhibition or decrease the RAS dose, you find that the mortality increases and the cardiovascular, cardiorenal adverse outcome or mortality with the prior RAS doses increases as you take the RAS inhibitor off board. So we come to a very important principle, which I want to highlight in this meeting, is that you actually, what's outcome related to the suboptimal therapy of RAS inhibition due to real or perceived risk of hyperkalemia. So if when you stop the treatment, the patient develops a worse outcome. And we will say that this patient had a cardiac failure and this outcome we attribute to the cardiac failure. No, we should not attribute to the heart or cardiac failure. Cardiac failure treatment can be modified by effective RAS inhibition. This should be actually attributed to the hyperkalemia. So the question comes that if you have drugs to reduce the potassium level in the body, can we think about using these molecules to reduce potassium level, which act in the GIT by decreasing the absorption of potassium, by excreting the potassium inside the GI system as a therapeutic enabler. Therapeutic enabler means what? Therapeutic enabler is the one which allows us to use full dose of RAS inhibition or upgrade the dose of RAS therapy in the patients without being afraid of hyperkalemia. And this is what the European Society people are telling us now. The first time European Society in 2021 addressed this potential issue of hyperkalemia, they said the life of the patient and the physician is very easy when the person remains in the normal calemic range. So when the potassium remains between 4.5 to 5, then the things have become very easy. If you see a patient in the clinic, if the patient is not on the maximum tolerated guideline recommended target dose of RAS inhibition, which I have put in the yellow box, you do nothing, but you increase the dose of RAS inhibition with the close monitoring of potassium. And if you have a patient who has got hyperkalemia, you have to decide, is it mild to moderate hyperkalemia and severe hyperkalemia? The one on the right-hand side is the patient with a severe hyperkalemia. It is potassium more than 6.5. Most of the cardiologist and physician will admit this patient inside the hospital, discontinue RAS inhibition, and will give them potassium-reducing agent, acute treatment, chronic treatment, and you can actually initiate potassium-lowering agent by you can actually start RAS inhibitions once the potassium level comes below normal by closely monitoring the potassium level and optimize the RAS inhibition whenever the patient potassium level crosses less than 5. For those people who have mild to moderate hyperkalemia, that is between 5 to 6, the European Society guidelines say that you can decrease the RAS inhibition therapy, initiate on them a potassium lowering agent, and you continue monitoring them every few days for him. And if the patient is able to tolerate, then you actually increase the level of RAS inhibition to the guideline recommended target therapy in this patient. So the guidelines, what type of agents do the European Society guidelines recommend? The European Society people recommend in their 2021 document the two compounds. What are the two compounds? One is a petiromer and the second one is sodium zirconium cyclosilicate. So these two patients are the molecules which are used in the population, in the patients with the heart failure and in this population. So both compounds, petiromer and the sodium zirconium cyclosilicate, are effective in normalizing elevated potassium level, maintaining normal kalemia over time, preventing the recurrence of hyperkalemia, and can be considered for the treatment of hyperkalemia. And this allows us to up-titrate RAS inhibition or up-titration in the large proportion of the patient. This is the position statement of European Society of Cardiology. So what is petiromer? Petiromer is a compound which is orally administered, non-absorbable, calcium-based potassium binding polymer. So it's a polymer which comes as sachet, can be dissolved in the water, can be dissolved in apple juice, can be dissolved in cranberry juice, and is indicated for the treatment of chronic hyperkalemia. It is not a treatment for acute hyperkalemia. Please, for acute hyperkalemia, the patient who is admitted, we have other therapies due to possible time, we're not going to it. So it is not for that treatment. It is indicated for the treatment of chronic hyperkalemia. And where it works, it acts on the colon. So this drug is a potassium binder. It goes to the colon where beads are excreted and absorbs the potassium, exchanges it to the calcium, and causes reduction in the potassium level. So it uses calcium as the exchange counter ion. And unlike sodium compound, SCZ, which uses sodium, this uses calcium. So thereby, in a patient with a cardiac patient, it is safe because we know that the heart failure patients are very much sensitive to the potassium load. And that is why we are giving direct to this patient. It acts primarily in the colon, where the concentration of potassium and the GI tract is the highest. And in the colon, when the calcium is released from the polymer, the calcium absorption is very, very low in the distal part of colon. There is some interactions with the other drugs. So the European Society recommends that this should be taken 3 hours apart from any other drug. Typically, the patient takes the drugs in the morning. We can ask the patient to take this drug in the afternoon time along with the food. The onset of action occurs immediately. It starts within 2 hours, but you can see a visible change in the potassium in 47 hours, and the drugs acts long. The action of the drug can persist for 36 hours. And if you stop the drug over 4 to 5 days, you will find that the potassium levels start rising in this population. So what petiromer allows RAS inhibition to the long-term potassium control, and this happens to us without the risk of edema because the sodium level is not changed in the human body. So the number of trials has been done with petiromer over time, and most of the trials are done in the patients who are receiving RAS inhibition at the baseline. Majority of the patients have some form of kidney disease, not necessarily on dialysis, but there's some form of kidney affection because the kidney is the source for hyperkalemia. Many of these patients are diabetic, so they have some amount of diabetic nephropathy. We know that diabetic nephropathy makes the patient prone to develop hyperkalemia, and a good number of patients have heart failure. So these are the typical patients we see in the practice. In these populations, the manufacturers done many trials, which are phase 2 trials, phase 3 trials, and the phase 4 trials. And one or two trials I will discuss by only showing one or two slides. So I will not bore you with many of this scientific content about it. So the two trials which I will discuss is the Pearl heart failure trial, the Umber trial, and the Opal trial. Among them, Pearl heart failure trial was the trial which was mainly used in the population in which they looked at how peteromer allows us to use spironolactone, and they found that the patients who are using peteromer versus placebo, the incidence of hyperkalemia reduced by 25% to 7%. So we can see a good reduction in the prevalence of hyperkalemia with a p-value very, very significant. And it allowed in most of the patients to increase the dose of spironolactone to 50 milligram per day, which is actually the guideline recommended dose for hyperkalemia. And such a dose I have for spironolactone was possible to be used in nearly 91% of patients. So this means that it enables us to use RAS inhibition to a maximum dose in the higher percentage of patients. Another trial which was done was the Opal HK trial, which included population with hypertension, heart failure, and most of the patients will receive RAS inhibitors. In this population, the use of peteromer over placebo allowed to doubling of the patients to receive RAS inhibitions. So you can see actually everybody in this trial, we were able to give them peteromer along, we were able to go RAS inhibitions when the patient received a baseline peteromer therapy. So baseline potassium reducing chelating agent allow us to enable us to use RAS inhibition in all these patients. Another trial was the Ember trial, and this Ember trial was a little bit important because this Ember trial showed that the population who developed hyperkalemia was reduced to half in which patients this included population with the kidney disease and the population with the resistant hypertension. We know the people with the kidney disease, they have a very high prevalence of hypertension, and we are traditionally using for them Eldomet and hydralazine and moxonidine, but these drugs are not effective because they require much more the higher degree level of blood pressure control. So the RAS inhibitions are withdrawn in most of the patients. So in these patients, along addition of peteromer, decrease the proportion of patients with hyperkalemia, and the hyperkalemia were defined as the potassium more than 5.5, being nearly half as compared to the placebo. So among the patients treated with placebo, nearly 66% of hyperkalemia, and when you give them peteromer, this incidence was reduced by the half. So if you take these three trials, which I showed you, the Opal trial and the Pearl trial and the Ember trial, it is very, very clear that peteromer enabled substantially more patients to remain on the RAS medications at the end of the study. For that matter, even upgradation of RAS medicines was possible. And the same thing you can say, it allowed us to initiate, continue, and uptitrate spironolactone in the patient with heart failure and or kidney disease in this population. So what I have to tell you that it's a very, very important drug in the clinical practice. And this was shown apart from the trial in the registry data. So this is a retrospective analysis from the data from the VA corporate data warehouse in which the patient had a baseline of heart failure, diabetes, or CKD, and they were treated with peteromer. And you can see that the hyperkalemia levels, the potassium levels came down by mean of nearly 1 to 1.2 milliequivalents per liter. So the baseline 5.8 has come to 4.8, 5.7 has come to 4.7. So this bring the potassium level below the cutoff level in our mind of 5. So at this point, I am sure all of us start RAS inhibition, but if the patient comes to you in the clinic with a potassium level 4.8, you will have no problem in continuing RAS inhibition in this patient. So what about the outcome data? So the researchers tried to do an outcome data in this population, which is called the Diamond study. The Diamond study is an outgoing study, but because of pandemic, there are things that have been changed by the FDA regarding the outcome data. Initially, the researchers tried to look at the primary endpoint, the time to the first occurrence of cardiovascular death and hospitalization, in which population, in the patient more than 18 years of age, patient with heart failure with a reduced EF. And in this patient, the researchers tried to show that if you continue RAS inhibitions along with the baseline of peteromer therapy, the patient can have an outcome benefit with regard to the cardiovascular death and the cardiovascular hospitalization. But because of COVID impact. So the endpoint is going to change, and this trial is ongoing. Now the endpoint is to look at the change in the serum potassium level and number of events with the potassium level more than 4.5. So we know this is like a surrogate marker. If the potassium is controlled, RAS inhibition is enabled, then more patient will develop the benefit. How about the safety of this molecule? The drug is quite safe. So these are the summary of adverse event taken from the reporting side, the FDA and European Society. So you can see that most of the effects which occurs in the patient with the fatty tumor is linked to the GI side effects. The common GI side effects is constipation, diarrhea, abdominal pain, and flatulence. This is not unexpected, but most of the people are able to tolerate. Many people require, hardly anybody requires discontinuation. Uncommon are nausea and vomiting. So these are tolerable GIT side effects. Our patients are polypharmacy, so you wouldn't know which drug is causing effect. The second one effect is the level on the magnesium. But about the magnesium, it is seen that the no patient develops serum potassium magnesium level less than 1 milligram, which is 0.4 milliequivalents per liter. So, but the recommendation is that serum magnesium should be monitored for at least 1 month after initial treatment. This is not difficult because the patient will have some monitoring of potassium after starting the treatment. So you have to give it. What is the dose? The dose of the drug comes in a sachet of 8.4 gram. It has to be taken once in a day. And like we said, 3 hours away from the medicines with a glass of water, can be with the glass, the apple juice, with a glass of cranberry juice. So it is a reasonably drug. With the water, you can take it and without any problems. What of interactions? It has got potential to bind oral co-administered medications, which can reduce the GI absorption. And like I said, it should be separated 3 hours away from the oral medicines. With this, I come to the end of the talk by saying certain things that we cardiologists love RAS inhibition. If the patient condition will allow, we'll give RAS inhibition to everybody. Guidelines advocate the use of RAS inhibition in multiple cardiac conditions, for example, in hypertension, in the patient with resistant hypertension, in patient with post-myocardial infarction with LV dysfunction. However, hyperkalemia is a relevant side effect. It is just not relevant. It is a very, very important, it's a disabling side effect and prevents many of these patients reaching effective dose of RAS inhibition. And finally, molecules such as petiromer being potassium binder is actually a great enabler for us to use as a cardioprotective and the renoprotective mechanisms of RAS inhibition. With this, I come to the end of the talk. And if there are any questions, I'll be happy to answer it.
Thanks, Dr. Agrawal, for this summary on this challenging problem, hyperkalemia and heart failure patients. I don't know if there's any questions. I see a question on cost effectiveness of potassium binders. Is there any answer to that question?
I didn't get the question.
One of our audience is asking cost effectiveness.
Cost effectiveness.
Yes.
Now we have to understand the patient with heart failure don't require one medicines. It requires a bunch of medicines. It requires RAS inhibitions, it requires dapagliflozin or empagliflozin, it requires beta blockers, it requires MRA. All these medicines cost money. So when you take the whole context of the patient's medicines, among the 4 medicines, which are 4 pillars for the heart failure, 2 pillars are linked to increase the potassium in the human body, particularly when you have background of kidney disease or you have background of diabetes mellitus. Imagine among the 4 medicines, 2 medicines you cannot use just because of the potassium is high. So that is why you have to use such a molecule in there. So we are in the government hospitals, you are in the government hospitals. We are not actually looking at the cost. We are looking at whether it can use this molecule and make the patient live longer.
Great, thank you. Is there any questions, Dr. Bakir, for Dr. Amri?
Question, Dr.
Or we can closure?
Now, when we are treating this, you are treating the elevated potassium, yes?
Yes.
Right. But the cause of the elevated potassium itself, we said that the renal function is leading to elevated potassium. So the question is about the cause of this elevated potassium. We are not treating it. We are treating only the elevated potassium. You get my point?
Yes.
What is
Yes,
your...
yes. So Dr. Sharif's question is that we are not addressing the cause for the elevated potassium. We are actually treating the effect of the cause of the elevated potassium. The reason is that the potassium elevation in the patient with heart failure is multifactorial. Multifactorial, when we say it is typically linked to the, obviously it is linked to the GFR, it is linked to the way the kidneys excrete potassium. Most of the potassium we know is handled by the kidney. The patients with the heart failure, they have a renal dysfunction, and also they have certain other subtle metabolism abnormality, which actually uh, accumulates potassium in the human body. This is the way the drugs act on the nephrons, a diseased kidney, and diabetic nephropathy by itself, because of multiple mechanisms, makes the patient more prone to develop hyperkalemia. Whatever the reason is that, once the patient develops hyperkalemia, how many of us will be comfortable in sending a patient home or a patient home with a potassium level of 5.8 and on RAS inhibitions? I'm sure all of us will stop it. The patient typically come after 3 months. He will come after 3 months, potassium is normal. Then you will read in the notes of the patient. There somebody is written there. RAS inhibition stopped because the patient developed episode of symptomatic hyperkalemia. His will be off RAS inhibitions.
Right. Uh, Sorry, Dr. Bakir. Anything?
No, excellent.
So thank you, Dr. Agarwal. This is great. I think, we are already almost 14 minutes beyond time. So I would just go ahead and conclude this session or this symposia. I would like to thank Dr. Sharif Bakir, Dr. Amrish Agarwal for their valuable time. I'd like to thank our attendees for their time throughout. The attendance have been consistent. No one left the room, and the interaction have been great. I saw at the end there was a lot of comments asking about repeating this. We have been doing it quarterly. We will look into doing it even more frequent. So thank you all for your participation. There's a CME certificates that the event organizer, our colleagues from ICOM, I would like to thank them all for their also for their work. They will share with you the CME certificate for this event. Thanks again, and have a good night.
Thank you.
شكرا
Thank you very
يعطيكم
much.